Okay, and last but definitely not least, we are joined by a medic, Richard. Yeah. Wherever he is, as he escaped the room. We have Dr. Manisha Narasimham. Yes, I've been practicing since 2 years ago when I couldn't say it. She's going to talk to us about movement disorders in frontotemporal dementia. Manisha is a neurologist and a PhD student with Frontier. Her special interests are movement disorders in frontotemporal lobar degeneration and the intersection between motor neuron disease and FTD. When not tending to the endless demands of work and children, both human and canine, Manisha loves to relax with a book and a cup of tea and a never-ending crochet project or projects. So, thanks, Manisha.
So, I think Mirelle's going to be a really hard act to follow. I was going to say that it's one of the best talks I've ever heard. And I have some personal reflections too. So I lost my mum several years ago. I am still grieving. And I couldn't figure out why in the last 8 years I've tried to play every musical instrument I can lay my hands on and given up. Currently it's the guitar. I try and cook as much as I can. I've taken up crochet, which I didn't need to, but I did. And I think it was because these were ways I feel close to her, because she was a beautiful seamstress. She used to sew all my clothes when I was younger. I didn't have anything bought from a shop. She cooked up a storm. We never had to buy snacks. Everything was made. She was very, very intelligent. She used to do complex cryptography and coding. She wrote a coding book. So in a way, this PhD is also, I think, an ode to my mum. So there's not a day goes by I don't think of her. I've still got voicemails. She's still on my favorite list, right on the top, on the phone. So, and also one reason why I've taken drinking tea to an Olympic sport level, because we have shared so many cups of tea. Every time I have a sip, I remember her. So, thank you, Mirelle. I want to say this is also one of the best audiences I ever talked to. You all remind me constantly why I took medicine. Well, I knew from when I was I think 10, I wanted to be a doctor. And I knew as soon as I joined medical school, I wanted to do neurology. So you're all the reason I do what I do. I don't know if I was good at it, but so what are movement disorders? When I talk to medical students, this is how we divide movement disorders. So they're involuntary movements, defined in different ways in different textbooks. But basically, we divide movement disorders into movements that are excessive to normal and then movements that are less than normal. So the excessive movements, these are the three main ones that would be relevant to this group. So the first one being tremor, and I've got a little video here. And tremor usually affects a limb, an extremity, but you can get head tremor. You can get tremor of the voice, tremor of the jaw, and in this patient with Parkinson's disease, you can see there's a one-sided limb tremor affecting the upper limb and the lower limb. And tremor is, in a way, defined as shaking. We also have this phenomenon called dystonia, which is excessive contraction, usually of the limb, but you can also get extensive contraction posturing of the neck. And in this video, this person's got a very tight clenched fist, which is a form of dystonia as well. The third involuntary movement is something called myoclonus, and towards the end of the video, that person's arm just lifts up with a jerk. So there you go, that's a myoclonic jerk. And myoclonus, again, usually affects an extremity. And then in terms of underactive movements, this is bradykinesia, where there is a progressive slowing of movement. In life, you're not going to see it this way. In life, you'll see somebody who's really very slow in doing things. So slow in turning in bed, slow in getting up out of bed, getting out of a chair, slow while walking or doing tasks, basically. We demonstrate it clinically with this action we call finger amplitude, where we demonstrate a reduction in the amplitude or in the speed of doing the task. Rigidity is something that cannot be demonstrated easily by video, but it's something we look for where there is stiffness in a limb. I'm aware that I have a vocal tremor. I don't know if it's the mic. So moving on, these are some of the terms that you would have encountered when you come here to Frontier, or when you read up on the internet, or come across in other people experiencing this. So I just thought I'd give some clarity to these names, which unfortunately neurology is besieged with lots of terms that we can't explain easily. So in your cooking pot, if you put bradykinesia or slowness of movement, and tremor, and rigidity or stiffness, with or without tremor, which is the shakes, you get what we call Parkinsonism. This is a, can you hear? Yeah, okay. So this is a picture of someone with Parkinson's disease, and typically patients quite stooped, they've got shuffling gait, they might have a tremor on one side when they walk, they're very slow, they can't turn easily. Yeah, when we have these Parkinsonism features that are different from Parkinson's disease, so not typical, we call it atypical Parkinsonism. So what are the atypical Parkinsonisms? This list was a bit longer when I was a medical student, but it has contracted, and there's basically three. The first being progressive supranuclear palsy, or PSP, corticobasal syndrome, or CBS, and then multiple system atrophy, or MSA. And for the purpose of this talk, I'll talk about the first two only. So how are these different from typical Parkinsonism or Parkinson's disease? So in Parkinson's disease, tremor is usually the first symptom. There is usually a resting tremor, which improves on action. It's usually asymmetric at onset and then becomes more symmetric. And then eye movements, balance, posture, all of that, it's quite late involved. Cognitive impairment also in typical Parkinson's disease tends to be seen later. And there are these non-motor features, which are thought to be quite typical: loss of smell and adrenal enactment behavior. And patients do very well with dopamine therapies, usually. The underlying pathology, and I'll talk about pathology later, is a protein we call alpha-synuclein. In atypical Parkinsonism, the reason it's so atypical is that patients may not have tremor. They may have a combination of tremors, often an action tremor. They can be quite symmetric, as in PSP, or asymmetric, as in CBS. And then, especially in PSP, we have very abnormal eye movements, and we can see them quite early on in most patients. In PSP, we also have early falls. We can have early cognitive impairment, and that's the focus of some of my talk today. And usually sense of smell is normal. There's no dream enactment that we see in Parkinson's, and patients don't always respond to dopamine therapies, but they're still worth trying. The underlying pathology is quite variable. Tau usually in PSP, but very variable in corticobasal syndrome, and I'll touch upon that later. So PSP, just playing the video. It looks like it's out of Frankenstein, but it's from the Movement Disorder Society. Sorry, I'm trying to get the, sorry, without the mouse, trying to, yeah, there we go. No, I got it. So as I've said, there's quite a symmetric Parkinsonism. Tremor is rare. There's severe rigidity, especially the neck and shoulders. There's a wide base gaze and curiously difficulty looking down, but that's because the eyes don't move up and down, and often they lose down gaze. You can't look down. So that's one of the sort of prototypical features: early balance issues and falls, early speech and swallow impairment, and there's very typical eye movement difficulty. And if you've been in front of me in clinic or some of the other neurologists, we'd have tested eye movements as well in keeping with this. There are also other features that I haven't touched upon here. So the Movement Disorder Society has described about 7 types of PSP. So there's variants where you have only gait freezing. There's variants where you have only incoordination or cerebellar ataxia, and there's variants where you have only speech and language disturbance, as we are discovering now, in the beginning at least. There's also variants with overlap with motor neuron disease. So it is not a simple syndrome to define or describe easily. And that is even despite the fact that the first description of PSP is more than a century old. This is not something we've discovered recently. So corticobasal syndrome, the other atypical Parkinsonism. In addition to the Parkinsonism, patients have these curious features. So apraxia, not easy to define, not easy to test for. So with apraxia, there is difficulty in learned behavior, for example, being able to demonstrate the use of something, for example, a comb, or a brush, in this instance, a toothbrush, being used for the wrong task, being unable to mimic gestures, but as I said, very difficult to define and difficult to examine for as well. In addition to that, patients have dystonia. They have myoclonus, like I showed you before, and this curious higher sensory center involvement. So this patient is actually trying to show us how to use a knife and fork, but can't. And you can see on the left side especially, there is this clenched posture of the fist. So that's actually dystonia. And then you will see lots of limb elevating maneuvers. So you get what's called spontaneous limb levitation. So that happens a lot in CBS. Sometimes it's so severe that there is no control over that limb, and it is what we call an alien limb. That's quite rare, but that's something we look for. With the higher sensory center involvement, some of you have sat in front of us in clinic will be wondering why we have in our little tool of curiosities a key and a coin and a biro cap and a paper clip, and that's because we're testing for this higher sensory ability. Get patients to close their eyes and put the object in their hand and see if they can identify what's there. That's a higher sensory function. The other thing we test for is the ability to recognize numbers drawn on the hand with the eyes closed. These are all testing higher sensory function. All right, so are there ways we can diagnose PSP and CBS in life? Unfortunately, it's often not beyond the clinical assessment. And I think these conditions are what keep neurologists in business, because there is no biomarker currently that we can use. There is no readily available biomarker. There's a lot of research, so watch this space. But currently, nothing substitutes for a good clinical assessment and also serial follow-ups, because people change over time, and that's really important. Imaging, so we can use some surrogate markers. A lot of the time in these patients, I use MRI helps rule out other things. But you can see something like this. So in PSP patients, you have midbrain atrophy, which is the upper part of the brainstem. It's quite curved and narrow compared to the normal, quite plump midbrain here. And it's been likened to the beak of a hummingbird. So this is the hummingbird sign in PSP. There's an index, a couple of indices as well, radiologically, that can be calculated. They are not foolproof. They can only be used as a guide. So sometimes if I have the clinical suspicion, I will look at the MRI and look for this. It's not going to replace a clinical assessment at all. Interestingly, just in movement disorder and Parkinson's, there's a whole menagerie of animals we managed to find on MRI. So there's Mickey Mouse, there's a panda, there's a tiger, and a few more. In CBS, again, not substituting for the clinical assessment, but once we have a clinical diagnosis, then you can often see this focal atrophy, either right or left, affecting frontal and parietal regions of the brain, extending sometimes to the occipital or the high visual center. Okay, so the hallmark of diagnosis is, of course, brain tissue. So brain donor programs have been very useful all across the world to help us identify what the clinical presentation of these pathological diagnoses are, and also the variability that we are now seeing in clinics. It's not quite new developments, but just bringing up what else we can use. So we've had PET imaging for a long time, so we use them in cancer. So much like that with the glucose tracer, we look at reduced uptake in the brain in areas that are not working. So I wouldn't recommend using these as standard in this setting, as in for PSP and CBS. As I said, the examination is the hallmark feature. But there have been research studies, and I've got some PET images here with the mouse that's not working. So the top one is PSP, where you can see frontal reduced uptake of glucose, and also in the basal ganglia. And then in corticobasal syndrome, it's usually asymmetric, as in the frontal cortex and the parietal cortex. What's exciting is tau PET imaging. So using the same PET imaging, but a tau tracer. So tau is a protein in the brain, and they have developed first and now second generation tracers that identify deposition of tau in the brain. It's an exciting field, but sadly not available outside of research centers, and not all research centers have them. I believe RPA might get some of these tracers, but I'm not sure. So this is what it looks like. So the top patient here has PSP, and the tau is this little uptake of orange, which is in the basal ganglia, which is a part of the brain that gives rise to Parkinsonism, and then also in the brainstem, which is quite typical for PSP. And these two bottom sets of images are for corticobasal syndrome. Again, here, lots of cortical involvement, quite different from PSP. Irrespective of whether they've got Alzheimer's also, and I'll explain why the Alzheimer's has come up. So in the last year, we have now got a blood biomarker for tau called P217. It is now starting to be used in Alzheimer's disease because tau is a protein that's seen in the brains of Alzheimer's patients. Whether the same P217 is going to be useful for our FTD patients, we don't know yet. So it's a question of watch this space. Sometimes, especially with corticobasal syndrome, having negative assessments for Alzheimer's does help narrow the field down to this is possibly going to be tau pathology. So having negative amyloid testing may be a useful positive test, but we don't have that kind of imaging to order on a daily basis. And at present, I think it's restricted only to spinal fluid in Australia and most of the world. In some countries in Europe, we have dopamine transporter scans. So sometimes if there are diagnostic difficulties, we can use them. But again, none of these replaces the clinical assessment. So this is the traditional FTD model where you have the behavioral variant and two language variants of FTD. However, this model is now expanding. So we have now a continuum, and this top bit is where all my interests lie. So this behavioral cognitive and language model extends out to involve motor neuron disease features, and that is clearly established. In the interest of time, I won't talk about it today, but the other one is with the movement disorder and atypical Parkinsonism. So we didn't know this when we first described FTD. This is a much later discovery. We also have disease evolution that we're seeing in this clinic as well here, where patients with language impairment like PNFA over the course of time develop Parkinsonism and are being reclassified as having PSP and CBS, and that I'm sure some of you are familiar with. We also have the two sides of the same coin, where we used to think of right semantic and left semantic dementia, but now we have reclassified, and rightly so. The right semantic dementia is right temporal variant of FTD, which I think is appropriate. So that very simple table became this over the years, and I've just kept it. This is my simplest version of it. It is far more complex depending on which paper you look at. So if you look, this big blue circle is behavioral variant FTD. You have the two language variants. You have motor neuron disease, which we know can present with BVFTD as well as language impairment. And we have the atypical Parkinsonism that appears to intersect with all of these on its own. So far more complex than we thought. So what is the reason for that? And that is probably this. So neurodegenerative disease, and what we see in clinic is probably just the tip of the iceberg. So we have patients who have symptoms, they undergo an assessment, they have a clinical diagnosis. With progression, the clinical diagnosis will be retained or changed. However, all of this is still the tip of the iceberg, and what is important was hiding under the surface, which is their underlying pathology. And that's important because therapies don't target the diagnosis, they target the pathology. So if we can't predict the pathology easily in life, that makes therapies really difficult. And this is really important because we haven't been limited by the knowledge or the technology with regards to developing therapies. There have been plenty of therapies, anti-tau therapies, for example. We've developed, there's so many anti-amyloid therapies. It's actually identifying the disease in the early stages and the appropriate patients that is the struggle. So that complexity is mirrored in what we know about frontotemporal degeneration. So two main pathologies that make part of this are tau and TDP, and we have the three syndromes that classically form FTD. So we know that tau and TDP both cause behavioral variant FTD. Semantic dementia is mostly TDP, but we know that can be caused by tau pathology as well. And both tau and TDP cause PNFA. TDP pathology also causes motor neuron disease, which is probably why the spectrum has now expanded. And these two atypical Parkinsonism syndromes, we know that tau pathology is probably the most important cause of PSP. Corticobasal syndrome is caused by tau, by TDP. Alzheimer's pathology, which causes Alzheimer's disease, and logopenic aphasia also causes corticobasal syndrome. So it is quite complex. And then illustrating that this is probably the model that we should be looking at for all neurodegeneration, we know that alpha-synuclein pathology causes Parkinson's disease and a few allied conditions. So our research question, or rather mine, has been, what is the impact of movement disorder in FTD? So studying the prevalence of movement disorder, whether it creates a negative impact on cognitive measurements in FTD, how do atypical Parkinsonism patients present, and when they present without Parkinsonism, what is their cognitive profile? So in terms of the prevalence, we found that in FTD patients, about 10 to 15% of patients with only language and behavioral symptoms presented with movement disorder to our clinic. So small numbers, but still significant, I felt. We did not observe any movement disorder in semantic dementia, however, on their first presentation to clinic. Among the atypical Parkinsonism patients, a third of patients with PSP did not have any movement disorder when they first presented, and that is quite important. 12% of CBS patients with CBS did not have any movement disorder when they presented first to our clinic. What is the impact of movement disorder on PNFA? So you're all familiar probably with the Addenbrooke's cognitive examination. We do it every time you come, and I will show people their performances also. Comparing that in patients with PNFA, you can see, the mouse is moving, yes. You can see in patients with PNFA here, patients without movement disorder did better than patients with movement disorder. And that's quite striking for PNFA and quite comparable for some of the others. I also found that patients with PSP and CBS have significant impairment on functional scores. You're also familiar with the Cambridge Behavioural Inventory, this questionnaire we give you every year. So when I looked at the everyday functions, self-care and abnormal behaviour, if you look, the higher scores are worse, so CBS patients did the worst, among others. There is also significant executive impairment in PSP. So executive functioning is being able to plan, multitask, prioritize, do things in a stepwise sequence, follow steps, troubleshoot. Everything we do, I mean, the amount that went into this talk. So there is significant executive impairment in PSP. So I've looked at a decline. So the lower the scores are, the worse they are. And this box reflects PSP. And patients with movement disorder here in the purple compared to patients with pink with PSP did worse. There is also surprisingly significant language impairment in corticobasal syndrome. So using the same model, the lower the boxes, the worse the scores are. And this is corticobasal syndrome. And again, when I looked at patients with and without the movement disorder, not much change, but still worse than the other groups. So just moving on to the last bit, which is the management of movement disorders and whether they're linked with FTD or not. Right. So FTDs are currently incurable, but we can focus on symptomatic treatment. Parkinson's disease is also incurable, but it is highly treatable. So it is logical that we use some of the techniques that have been tried and tested for Parkinson's disease in our atypical Parkinsonism patients. So as with everything, I divide therapies into pharmacological and non-pharmacological, so our pills and potions. So a few strategies here. I always say for patients with atypical Parkinsonism that a trial of levodopa or dopaminergic therapy is really important and should be considered in every patient. Unlike Parkinson's disease, I normally give higher doses and quicker escalation. So you sort of judge because higher doses may be needed in PSP, for example. In PSBD, there is a role for a drug called amantadine, which is an antiviral agent. We use it for drug-related complications in Parkinson's disease, but it may improve walking in PSP. So at least worth a try in the younger patient, keeping in mind it can cause cognitive issues. And then tremor is a challenge to treat, whether patients have Parkinson's disease or tremor due to another cause. So it's very disabling. I try some propranolol, but can be limited in action by side effects, sometimes gabapentin. In Parkinson's disease, dopamine therapies do not help very often with tremor. So tremor tends to be the one symptom or sign that doesn't respond. Dystonia, I've put anticholinergics there, but I generally don't prescribe them. Some people do still, but there's lots of side effects. The only therapy that is probably effective is botulinum toxin, and I recently told someone in the clinic as well. So never underestimate the impact that symptomatic treatment of a fixed arm, a contracted arm, can have on the patient. It's not very difficult to give Botox. It has to be accompanied by physio and OT following that, but it can improve quality of life significantly. We often use a bit of clonazepam for both myoclonus and dystonia. Sometimes if the myoclonus is really disabling, you can try anti-seizure medications such as Keppra and lamotrigine. In cortical basal syndrome, because a third of patients have underlying Alzheimer's disease pathology, I will suggest a trial of cholinesterase inhibition, which is donepezil, Aricept, or some of the other medications that are available on PBS. Curiously, also may be an option for the gate freezing variety of PSP. There is some thought that that might help. And then I've put symptomatic therapies at the end there, but they are really, really important and should be used all through the patient's journeys, whether it's speech assessment, OT assessments, functional help at home, assisted devices, walking aids, physio, management of bowel, management of bladder, all that's really, really important. And non-pharmacological strategies, it can be simple things like fall prevention to a full-fledged gym rehab program. You can take your pick, whatever suits people. And so principles of exercise therapy start early, right in the beginning. At least 30 minutes a day. It should be challenging to have an effect. It should be individually tailored to the patient. No point making someone who doesn't like dancing dance, because they're not going to engage in it. So there's often an emotional attachment to what you make patients do. Always remember to false assessment, false mitigation. The activity has to be safe, should not make patients worse. And osteoporosis, important thing to screen for and also treat if it's there. So it could be a simple thing like walking with appropriate supervision and the assistive aid. Pedaling, I'm a big fan of pedaling in anyone with Parkinson's disease or Parkinsonism. And its beauty is that you can do it sitting. So if you've got someone who's unsafe to walk, they can pedal in a chair while watching TV. And you can put it on a table and get them to pedal with their arms as well. It does improve coordination, definitely. And I've seen it help. It's not going to fix the problem, but it is better than not doing anything. I think that's a picture of Kmart pedals, about $40 or something. So, sorry, it's... So exercise therapy is not simply me telling people what to do. So there's been some science behind it. There is this technique called rhythmic auditory cueing. So it's based on the premise that brain areas that control rhythm processing are also involved in movement, and that external cues may entrain movement by replacing the faulty mechanism. So I explained to patients there's a block maybe in the basal ganglia, and maybe the cueing exercise overcomes the block and finds an alternative pathway of movement. And the research does show that even when the therapy stops, there is a carry-on positive effect. So you can see on the graph, so the cadence step still remains quite good. It stabilizes and plateaus, but it doesn't fall. Neither does the velocity. Stride length may fall, but it's better than when they started. So there is a sort of take-home added benefit. And this is a very badly shot video of somebody who's gone through therapy. So you can see on the right, they've not had the cueing and they're slow, turns are slow. They're much behind the person the same person on the left after receiving the therapy. So other things, I'm very fond of Tai Chi because I think it is good for the patient who cannot walk safely. It can be done in a chair. It concentrates on movement coordination. It's not a cardio activity. So it's, I think, really good for people who've got movement coordination problems, like in Parkinson's disease and allied conditions. And as I said, it can be done anywhere, in a dance hall, in a chair.
Forward, back. Can't remember. Forward, back,
and then dancing, any mode of dancing, whatever people like. And it can be simple things like this video here where they're just moving.
Different kind of experience than they do.
Yeah. So I'm going to finish with the last couple of slides. The ongoing research into therapeutics. There are multiple trials in America, both out of San Francisco and the Mayo Clinic. There's a trial in the UK studying a novel product in PSP called the Study Prosper trial. There's so many. When I looked, I couldn't, the list was endless, but these are the major ones I've put up here. There's some useful websites as well, Australian and international, on PSP and CBS, things to look at. I think Frontier's been upgraded as well to reflect all these. So conclusions, a movement disorder and Parkinsonism clearly extend the disease spectrum of frontotemporal dementia. Movement disorder impacts cognitive and daily function in FTD, and this should not be underestimated. There are implications for lots of things like independence, quality of life, relationships, communications, finances, driving. The list is endless. There may be some ways to mitigate the physical effects of movement disorder, specifically exercise therapies. So I always say there's no side effects from the exercise. If we make it into a pill, everyone would take it. So in conclusion, I'd like to thank all of you for incredibly generous contribution to all our research, including mine, my PhD supervisors, all the wonderful people I work with in Frontier, who you can see here. And I think someone mentioned an assistance dog. Yes, it was so lovely. So I thought I'd put my own fur baby's picture there. That's Freya. She's a rough collie. She couldn't be an assistance dog because she's too distracted, but some of the smooth collies are actually.